So today it is going to be a feast of cases which Gaurav is going to present, covering ependymomas, high and low grade pediatric gliomas, and choroid plexus tumors. So, and I always find a pleasure in the way Gaurav presents his cases. So, Gaurav, let's start.
So I request everybody to hear it patiently and carefully. So right away, starting from the cases, and we will be discussing subsequently the topics discussing after the cases. So the case one is 13-year female who presented with intractable seizures and had a right frontal lesion. So when we saw the morphology, uh, here we can see this circumscribed uh, tight concentric whorls or nodules within the cortical or at the junction of cortex and white matter. See, this is the white matter, and this entire is the cortex or cortical zone. You can see here the pia matter, lining of pia matter, which is subpia, and this is nodular whorl schwannoma-like nodular aggregate of tight concentric interlacing fascicles of spindle-shaped cells. This is another picture. This is another area. These were two nodules actually lying side by side. So uh, this is a very this was the first time I was coming across. I was looking at this kind of morphology of a tumor, and I I I I could judge that this is a very typical kind of morphology of some tumor, but I was not aware what kind of tumor it is. But yes, there was definitely a very typical kind of morphology of concentric schwannoma-like whorls in the cortex. So I must turn up the pages. What could be this? What could be this kind of tumor which is showing this typical nodular pattern of appearance? So while looking at it, I can compare it with like a firecracker with uh, cells arranged around these center whirl-like appearance, or this the paper fan which we used to play in our childhood age group. So so this is a childhood age group tumor only and is showing similar kind of pattern. Here was the clicking point where I could see the radial arrangement of the tumor cells around these vessels. So radial arrangement of tumor cells around of spindle-shaped cells, which is showing the multi-layering and present in the cortex, presenting with intractable epilepsy. Here also we can see this vessel and the tumor cells are present around these vessels. Going to the high part, this is a very, very beautiful picture. This is the junction of the tumor. See, this is the tumor and this is the uh, white matter area. So here we can see the center. In the center, we can see a vessel, and this is multi-layered sleeve of the tumor cells. This is again multi-layered sleeve of the tumor cells. So basically, tumor is infiltrating out of the main tumor nodule, but very minimal. And after this, we don't see any sort of infiltration. But definitely, the tumor cells are arranged around these small vessels, and the cells are uniform, bland, spindle-shaped, without any pleomorphism, no mitosis, no necrosis, no endothelial proliferation. So definitely it's a low-grade tumor with concentric schwannoma-like nodular appearance on low part, and on high part, the tumor cells are arranged around the blood vessels and they are bland spindle-shaped tumor cells. So any guess on the diagnosis, on the basis of diagnosis, on the basis of morphology, sorry, just on the basis of morphology. So a low-grade pediatric tumor which is showing perivascular arrangement of tumor cells in a whirl-like fashion, radially arrangement of tumor cells around the blood vessels. Anyone if wants to try, please tell in the WhatsApp group. So let's proceed. I don't think anyone is even trying to attempt this. So here again another picture or high par of that previous picture. We can see the center vessel and the tumor cells arranged around these vessels. GFAP is strong and diffuse positive, and it's highlighting this nodular aggregate of tumor cells. CD34, I can CD34 is showing, we can see the CD34 highlights these vessels, small vessels, and the tumor cells are present around these vessels. You can see here this small enucleate zone and the tumor cells present around these vessels. So, first of all, what comes to our mind seeing this perivascular arrangement? Ependymoma. But the location is not that of ependymoma. So, we get to, we'll do the EMA and OLIC2. So, on EMA, we could see the focal dot-like positivity. Then again, it gives a strong impression that we are dealing with an ependymoma, but the location is not of ependymoma. OLIC2 is negative in the tumor cells, and in the surrounding cortical area, it is showing in some scattered oligodendrocytes. So it's a normal component, but the tumor cells are negative for OLIC2. So again, OLIC2 negative EMA dot positive perivascular perivascular arrangement. Most likely, it appears that we are dealing with some ependymoma. But Ki-67 was very low, and seeing the concentric location and as also the area was not there, so the diagnosis was angiocentric glioma, seen as WHO grade 1. So this was the first time I came across this entity. This is a low-grade tumor. So coming to the pediatric low-grade gliomas first, these are grade 1 tumors, and these are diffuse astrocytoma, MIB or MIB-L1 altered, angiocentric glioma, pleomorphic neuroepithelial tumor of young, and diffuse low-grade glioma, MAP kinase pathway altered. The first two tumors, which are showing MIB or MIB-L1 alteration, are very similar. Even the diffuse astrocytoma MIB-L1 altered can also show the pattern similar to angiocentric glioma. Just now we saw it. Because they both have MIB alteration. Only the fusion partner in angiocentric glioma and this entity are different. Here, in angiocentric glioma, the fusion partner of MIB is QK1, while here there are different fusion partners. So there may be some morphological overlap between these two. And the rest, these two entities are also very similar because they both show FGFR and BRAF V600E mutation. So pleomorphic neuroepithelial tumor of young and diffuse low-grade glioma MAP kinase pathway altered, they both similar to each other, while these two are similar to each other. So it becomes easy to remind these four entities.
So, Gaurav, just to clarify, both ependymoma and angiocentric gliomas are GFAP positive, and they are OLIG2 negative, and they can show ependymoma or EMA dot positive. So, how do we differentiate them on, because angiocentric glioma is also a morphological diagnosis more than the anything else initially. So how do we differentiate it from ependymoma? Because ependymoma can also occur in extraventricular location. It's not necessarily that you see ependymoma in and around the ventricles.
Okay, is this a question coming or?
Yes. Question to you. What are the pointers on morphology that we should see before we call or suspect angiocentric glioma?
Yes. First of all, the morphology was very typical. We don't see such kind of nodular kind of appearance in ependymomas, and it's very much cortical based. So cortical based tumors are rare in ependymoma, though extraventricular ependymomas can be seen, but those supratentorial ependymomas are more common in bit younger, like in children aged more than 10 years or in adults. And but in such a young patient, it's rare to see ependymoma, and with this kind of morphology, it's not ependymoma. And Ki-67 is very low in ependymomas. Supratentorial ependymomas have poorer prognosis compared to all other locations. Even infratentorial ependymomas have better prognosis than spinal ependymomas have better prognosis. They generally have high K57 index. And the cellularity is also is not like that of ependymoma. I will show you the cells in ependymoma. They are not spindle shaped. They are monomorphic, present in very much fibrillary matrix. They are spindle shaped, although they are arranged around vessels. But the arrangement around the vessels in supratentorial ependymoma is a bit different. And also, I would like to add one more point here. It's very important that the supratentorial ependymoma, which has negative TAPM positive, in those cases, rosettes are very less likely to see. It's very uncommon to see rosettes or true rosettes or ependymal rosettes in supratentorial ependymoma, which are L1 camp or ependymoma based on morphology as well. Although it's a remote differential, because I was not aware of this entity, so the perivascular arrangement was giving me to raise a differential diagnosis of ependymoma. But I knew in my mind that it's not an ependymoma. But when I turned on the pages of the book, then I could see that this is very much typical of endosynthetic glioma. Once you must go through the book and see the morphology and read about it, you will definitely nod with this that this is endosynthetic glioma.
Yeah, the cortical location, the nodular pattern, and the elongated nuclei and elongated cells which are perpendicular to the central vessel. All these are point towards it being an endosynthetic glioma rather than an ependymoma.
Endosynthetic glioma.
Yes, please continue.
And ependymomas, when ZFTF, yes, ma'am. Yes. We will discuss ependymoma as well in detail. We will differentiate there. So I told you that these two entities are very much similar to each other. Diffuse astrocytoma may involve altered and endosynthetic glioma. So what are the common features? They both show MIB alteration, that I have already told you. The only difference is the fusion partner is different in endosynthetic glioma, while here the fusion partners are different, MMP16 and MAML2. They both cause intractable epilepsy. They are also called as long-term epilepsy associated tumor. PLNTY, polymorphous neuroepithelial tumor of young, is also a long-term epilepsy associated because it is epilepsy associated tumor. So it's quite obvious that the location is most common location would be temporal lobe. They both have overlapping histology because the MIB L1 alteration is there in both these entities. At some areas in MIB L1 altered, angiocentric pattern can also be appreciated, but it's not exclusively and very much nodular like as we saw in angiocentric glioma. And here the tumor cells are negative for OLIG2 and CD34. CD34 is a feature of PLNTY. We will discuss ahead. So mitosis is rare or absent. Microvascular proliferation will be absent. It will be IDH wild type, and H3 histones will also be wild type. So these are the two. We are covering the two gliomas, two pediatric low-grade gliomas together. So what are the differences between these two? So the diffuse astrocytoma MIB or MIB L1 altered will show a picture very similar to a low-grade glioma, like other low-grade gliomas. Here I have taken the picture of a IDH mutant diffuse low-grade glioma, which is grade 2. But in this case, the cellularity is even less than grade 2 gliomas. I didn't have the picture of this case because we are yet to come across this case. Moreover, we have to have this kind of mutation, method of detection of this mutation. Then only we can call a diagnosis that diffuse astrocytoma is L1. So they are located at cortical and subcortical location, while they are located typically in the cerebral cortex, as we saw in our case. They have morphology similar to conventional low-grade diffuse gliomas, while they have distinct morphology which have schwannoma-like nodules. They have only slight increase in cellularity with low-grade nuclear atypia. Sometimes even they become difficult to differentiate from normal parenchyma. And in those cases, when we can highlight the infiltrative nature with the help of OLIG2. That means the entrapped or neuron or synaptophysin, like the entrapped neurons will be highlighted, or the entrapped oligodendrocytes will be highlighted with those markers. So in those cases, olive 2 may help, and only then we can get to know that it's an infiltrative glioma. The cellularity is so good, and cells show astrocytic differentiation only. And here cells are showing astrocytic as well as ependymal differentiation because the cells were EMA positive, and there is typical radial arrangement of tumor cells around the vessels of all calibers. So these are the differences between diffuse astrocytoma with L1 altered or endocentric glioma. Coming to next two entities, which are pleomorphic neuroepithelial tumor of young and diffuse low-grade glioma, MAP kinase pathway altered. So there are many tumors of CNS which have RAS MAP kinase pathway activation, and these are the all events which ultimately end up at RAS MAP kinase pathway. One is BRAF V600E mutation, and this mutation is seen in polymorphous neuroepithelial tumor of young, the pediatric low-grade glioma, diffuse low-grade glioma, MAP kinase pathway altered, supratentorial pilocytic astrocytoma. Remember, the supratentorial pilocytic astrocytoma may show BRAF V600E mutation, while the cerebellar pilocytic astrocytoma show BRAF GA1549 fusion, and the optic pathway gliomas or optic pathway pilocytic astrocytomas show NF1 gene alteration. So pilocytic astrocytomas in pediatric gliomas, genetic mutation very much correlates with the site of tumor as well. So it's a very good indication that what kind of mutation we are going to see in particular type of tumor depending on the location. So pilocytic astrocytomas mutation varies with the location. If it is an optic pathway, it's an F1 gene. If it is cerebellar, it's going to be BRAF 1549 fusion. And if it is cerebellar, more commonly it will be BRAF V600E mutation. So other tumors which show BRAF V600E mutation are PXA. PXA in addition will show CDK and 2A2B deletion as well. Then ganglioglioma, then DNET, desmoplastic infantile ganglioglioma. Now coming to then there can be FGFR1 gene fusions or FGFR2 and 3 gene fusions. So 2 and 3 gene fusions are seen in this PLNTY, and FGFR1 gene mutation fusion is seen in DNTs and diffuse low-grade glioma, MAP kinase pathway, and this ultimately leads to tumorigenesis. So this figure is very important, and one must have some idea that what are all the gene mutations which lead to RAS MAP kinase pathway activation. So coming to salient features of PLNTY, so far we have not seen this case, but it has very typical morphology and typical features. So we are going to discuss only the relevant features and important ones. So this is one of the long-term epilepsy-associated tumors and which involves temporal lobes. So it goes without saying if it is epilepsy-associated, more commonly it will involve temporal lobes. It will have typical solid and cystic components with calcification on radiology. And mutation we have discussed, because MAP kinase pathway of activation is there, so there will be BRAF V600E and FGFR2 and 3 fusion. In diffuse low-grade glioma, MAP kinase pathway altered, it will be BRAF V600E and FGFR1 fusion. So on morphology, it will show oligodendro-like cells, or with some areas may be showing astrocytic or ambiguous morphology with calcification. So it will be on IHC, it will be positive for GFAP. OLIC2, remember the first two entities, diffuse astrocytoma mid L1 altered was negative for OLIC2. Then endocentric glioma was also negative for OLIC2. But then further, these two entities, PLNTY and diffuse low-grade glioma, diffuse low-grade glioma, MAP kinase pathway altered will be OLIC2 positive. So first two entities were negative for OLIC2. Next two entities, third and fourth entities are positive for OLIC2. So GFA34 immunopositivity is seen in ganglioblastoma and in PXA. But here we also seeing here CD34 positive. BRAF V600E is also positive. There is one exception here, which is FGFR TAC3 fusion. This FGFR TAC3 fusion is a feature of high-grade glioma, and with copy number changes, which this also have copy number changes which are similar to IDH wild-type high-grade glioma. The features which are not seen here are microcysts, rosenthal fibers, myxoid matrix, rosettes, microvascular proliferation necrosis, because it's a low-grade glioma, so we are not going to come across any kind of vascular proliferation, necrosis, dermatocytic change, or mitotic activity. So this is very important that although the entity which resembles PLNTY but show a different fusion is a feature of high-grade glioma. So now the most important point, how to diagnose it. If we are coming across a tumor which is showing low-grade oligodendroglioma-like morphology in a young child who presented with intractable seizures, and the tumor is IDH wild type. So uh, here comes the pitfall. This is IDH wild type. Oligodendroglioma, which is showing IDH wild type. So obviously, oligodendrogliomas are very uncommon in pediatric age group. So if we are coming across a tumor which is showing ODG-like picture with IDH wild type phenotype and OLIG2 positive and CD34 positivity, we must think of polymorphous low-grade neuroepithelial tumor of young. But again, the important point that we must rule out this fusion because this fusion is a feature of high-grade glioma. So morphologically, it may be PLNTY, but there are chances that it may be a high-grade glioma, so we must rule out this entity. Now, the last entity of pediatric low-grade glioma is diffuse low-grade glioma MAPK. Symptoms depending on the site involved anywhere in the craniospinal axis. Unlike the previous three, which were there in temporal lobe presented with epilepsy only. But here, this diffuse low-grade glioma MAPK can be present anywhere in the craniospinal axis. Radiology is not much significant, but yes, BRAF600D mutation will be there, like in PLNTY, but and the SGFR fusion will be different. Here, the SGFR1 mutant or SGFR2 mutant with TKD duplication, tyrosine kinase domain undergoes duplication. Again, the morphology can be ODG-like or astrocytic, and GFAP, OLIG2, and BRAF600D will be positive. Again, the features which are of high grade will be missing in this entity as well. So if we are seeing a low grade astrocytic or oligodendroglioma like morphology in a young child with BRAF positivity or SGFR mutant, IDH wild type, OLIG2 positivity, it's a diffuse low grade glioma MAPK. BRAF can be detected by IHC easily, so we must include this BRAF low-grade gliomas in pediatric. So these were the pediatric low-grade gliomas. I have shown you this case, and based on this case, we have discussed all these four. These two are similar. These two are similar. The third and fourth. Now coming to next case. Although the age is not fitting into pediatric age group, but the tumor is of pediatric age group. So 33-year female presented with progressive quadricuresis and the spinal intramedullary glioma, very high-grade glioma. So this is the picture. The tumor cells are showing oligodendroglioma-like morphology. Cells are uniform. There are areas of microvascular proliferation. And here we can see a thrombosed vessel. There were large areas of necrosis. I couldn't include that in the picture because the areas were quite large and they were not at the interface. So GFAP is positive in these tumor cells. OLIG2 is positive. IDH1 is negative. So picture was that of oligo-like cells were there, but IDH1 is negative. And ATRX is showing mutant expression or ATRX is lost. So anyone for the diagnosis? Spinal cord tumor, 33-year male patient. So this is further IHC. CD34 is positive, P53 is showing wild type, and K67 is very high. So this is the most important IHC in this case. This is H3K27M and this is H3K27ME3. So here we can see that ME3 is lost. It is positive in the endothelial cell, while H3K27M is positive in all the tumor cell nuclei, while it is negative in the endothelial cells. So here the negative, here the internal control is negative endothelial cells, and here the internal control is positive endothelial cells in ME3. So these are the most common, these are the most important ISC markers for this entity. This is diffuse midline glioma, HPK27 altered, CNS WHO grade 4. Coming to the next case, this is 51-year male presented with altered behavior, memory dysfunction, and headache, and third ventricular as well. Now here, because it's a third ventricular tumor in diffuse midline glioma, it's very common to see that the tumor tissue is very scant because it's difficult location and the surgeon may not be able to reach and excise the entire tumor. So we generally get very scant tissue. So this was the only tumor tissue bit which we got, and definitely we could see that the cellularity is a bit towards higher side, and the cells are relatively uniform with very less or minimal pleomorphism, and there are branching vessels in the background with some myxoid kind of consistency, with myxoid kind of fibrillary matrix. But yes, we could see the mitosis, in fact, two mitosis in single hyperfield. So definitely the increased cellularity, cells with minimal pleomorphism raises the suspicion of a high-grade glioma. Then GFAP was positive, OLIG2 is positive, IDH1 is negative, and ATRX is also lost. Then, because it's a midline tumor, we must go for H3K27M. This is high part, showing each and every nuclei positive expression, while endothelial cells are negative, and ME3 is lost. P53 is showing mutant expression. CD34, although not much of use in this case, and Ki67 is high. So again, this is a case of diffuse midline glioma, HPK27 altered, CNS WHO grade 4. This is case 4, which is 14-year male patient, right thalamic SOS. Here again, we see the tumor with different uh, areas with different cells, with different uh, grade of cellularity. Here, the tumor in this tissue with cellularity is bit higher side, while here the cellularity is low, and we don't see very high grade nuclear pleomorphism. Tumor cells are again small size with minimal kind of pleomorphism, and necrosis and microvascular proliferation are not seen here. Here the cells are looking like oligo, showing oligo-like picture. Again, GFAP positive, OLIG2 positive, IDH1 is negative, and ATRX is showing loss, loss of expression. H3K27, each very beautiful, each and every cell showing strong nuclear expression, and this endothelial cells are negative, and ME3 is showing retained expression in endothelial cells only, while the tumor cells have lost this expression. And P53 is wild type and K57 is high. So again, this is a diffuse midline glioma, HPK27 altered, CNS WHO grade 4. So in all these three cases, what we saw, the common thing was only in the first case we could see that there were necrosis and endothelial proliferation. In rest of the two tumors, there were only cellularity was high, and in one of the cases we could see the mitosis as well. And the immunohistochemical profile was similar in all the three cases. Two were adults and one was 14-year male. And all these tumors were located in the midline. One was in thalamus, one was in the spine, and one was involving the ventricle. So these are the typical features of diffuse midline gliomas. So coming to the pediatric high-grade glioma group. These are grade 4 tumors. The most common ones are diffuse midline glioma, HPK27 altered. Earlier it was called as HPK27 mutant, but now it is called as altered because there are several ways by which the mutations in histone genes, in the genes encoding histones can happen. So people have identified different ways of mutation. So we instead of calling HPK27 mutant, it's called as HPK27 altered. Then The non-midline location hybrid gliomas are called as diffuse hemispheric gliomas, and there we see H3G34 mutation commonly. Then diffuse pediatric type high-grade gliomas where histone proteins are wild type and IDH is also wild type. Then last entity is infantile type hemispheric glioma. So the most common ones are diffuse midline glioma HCK27 altered. We have seen the cases. We will go for the brief discussion about these. So there are basically two variants of histone proteins which are encoded by three genes. The H3.3 histone, which is encoded by gene H3F3A, then H3.1 histone, which is encoded by two genes HIST1 H3B and HIST1 H3C. Now there are four subtypes of diffuse midline glioma of H3K27 altered. That means by four ways this H3K27 can get alteration. One is the classic one, which is the most common type, in which lysine is replaced by methionine at 27 position. This ultimately leads to increased nuclear expression of mutant protein. So basically, what is H3K27? It's an antibody against the mutant protein, against the mutant histone, which highlights the nuclear expression. And this ultimately leads to reduced PRC2 expression, and this ultimately leads to decreased expression of H3K27ME3. So in normal cells, its expression is retained, while because HCK27 mutation does not happen and it's in normal cells, it will be negative, as we saw in the internal endothelial cells, which was negative, as negative internal control. Now, H3.1 or H3.2 K27 mutant, this again leads to decreased Me3 expression. But here the K27M mutant IFC may not be helpful, but Me3 expression will be consistently low. Then diffuse midline glioma H3 wild type with EZHIP overexpression. Here also we cannot, in this case HCK27 M will also be positive, but in this case where H3 wild type but EZHIP overexpression, this also ultimately leads to PRC2 suppression, which ultimately leads to decreased Me3 expression. So decreased Me3 expression is the common finding. HCK27 mutant protein will be highlighted in these two entities, but not in this entity. Then there is diffuse midline glioma, EGFR mutant. This is the rarest type, and we have yet to come across more number of cases to study this in detail. But yes, the most common one which we come across is H3.3 K27 ME. There are many other accompanying driving mutations also in these tumors. The most common ones are P53 mutation and the ATRX loss. In all our cases, there was accompanying ATRX loss. This is also very important. What all the structures are included in the midline. It includes the tumors in brainstem, pons, thalamus, and spine, while the tumors in cerebellum, pineal region, and hypothalamus are not included. So the next entity of pediatric hybrid glioma is diffuse hemispheric glioma H3.3G34 R or B. That means arginine is replaced by glycine is replaced by arginine or valine at position 34 in H3 gene. So this is hemispheric or non-midline location. It's highly cellular, showing risk mitosis, necrosis, and microvascular proliferation commonly present, but they are not mandatory. Like in HCK27 mutant also, we can see necrosis and microvascular proliferation, but they are not mandatory to diagnose these entities. They may resemble embryonal tumors as well, morphologically, because they are small, round, undifferentiated cells and may show hemorrhoid rosettes. Microvascular proliferation and necrosis are less common when they show embryonal tumor morphology. On IFC, ATRX will be lost in 95% of cases. P53 will be mutated in 90% of cases. OLIG2 will be negative and G34R/2 will be positive on ISC. So it has a very typical and very different spectrum of ISC expression if we compare it to H3K27M mutation. ATRH can be lost in 20% of cases in H3K27 mutant and 353 is
Losing
more
your
commonly
voice.
mutated in this
Gaurav, losing your
H3K27.
voice. I think you should come close to the speaker.
It all hello.
Yes,
Is
yes.
it
Now
okay
good.
now? Okay. So these are very two important difference in H3K27 and H3G34 that these H3G34 mutant gliomas are OLIG2 negative, while H3K27 are consistently OLIG2 positive. Then the last entity in second last entity in diffuse pediatric high-grade gliomas is H3 wild type and IDH wild type. Here there are three subtypes. There are mutation. There can be mutation in receptor tyrosine kinase, and depending on the location, there is some correlation with location also. Those which are RTK2 type are supratentorial and they show PLGFR-A amplification. RTK1 type show EGFR amplification. They are all are more common in supratentorial, but they are exclusively found in supratentorial location, while they can be seen in infratentorial location as well, but less common. And this is very important that these tumors resemble those arising secondary to radiation or which show constitutive mismatch repair deficiency, those with Lynch syndrome or Lee-Romanes syndrome. Especially the RTK1 type fits into this entity. But it is still to be proven that these tumors are different from this H3 wild type and IDH wild type or they belong to the same entity. Morphologically, they are very similar to GBM or they may show primitive undifferentiated morphology as well. The MIC-N subtype typically shows biphasic morphology, showing cellular circumscribed nodules and diffuse infiltrating patterns. So there will be mix of spindle cells and epithelial cells in MIC-N subtype. GFAP and OLIG2 positivity will be focal and MIC-N subtype will be negative for glial markers. Instead, they will be positive for neuronal markers. So, because they are also showing mismatch repair deficiency, so there may be some response to immunotherapy as well. So, these are again very rare tumors. So, one must be aware that they are positive for GFAP or OLIG2, but the MIC-N subtype are negative for GFAP and OLIG2. Then the last entity in this group, infantile type hemispheric glioma, they show RTK fusions, receptor tyrosine kinase fusions, which can be of anti-RK1, 2, 3, or ALK fusion positive. They can show ROS mutation or they can show BET gene mutation. They are generally supratentorial large masses on radiology. And morphologically, again, they are similar to high-grade astrocytomas or they can show pictures similar to GBM. And again, they will be showing conventional high-grade morphology like high cellularity, mitosis, cyclosphere proliferation, and cell division necrosis. Because they are ALK fusion positive and NTRK fusion positive, they also respond to ALK inhibitors. But the exact results of ALK inhibitors are yet to be published. So these were the pediatric high-grade gliomas. The most important feature of pediatric high-grade glioma was H3K27 mutation. So I would like to stress upon that having these two IHC markers are very helpful. This H3K27M mutant protein, which will be expressed in the nuclei, while ME3 will be lost with this kind of mutation. With the help of these two IHCs, we can diagnose most of these cases. Then coming to the ependymomas. Earlier ependymomas were not classified according to the location. If we talk about before 2007, they were conventionally graded like as we grade other gliomas or other astrocytomas like grade 1, 2, 3, 4, depending on the microvascular proliferation, necrosis, and mitosis. But gradually, we have seen that there are very typical location-related specific mutation in these ependymoma groups. So in 2016, it was introduced, the location was introduced, and it was established that the histological findings or histological grading does not play much relevance in the prognostic implication. And now they are 100% sure that, and in fact, in 2022, in WHO CNS fifth edition, in ependymomas, location and molecular classification is a must. But still, because of unavailability of these mutation analysis, they still allow to classify them histologically, and we can define the ependymomas on the basis of histology in two conditions. Like, ependymomas may still be defined by anatomical location but not by molecular alteration in two conditions. Like, if there is different molecular alteration, like if we are seeing mutation which are different from that of particular site. In those cases, we will use the suffix NET, not elsewhere classified. Or if the molecular analysis is unavailable or if it fails, then we can classify it on the basis of histological grade using the suffix NO. But the term anaplastic is no longer required. And one thing more important is MVP, microvascular proliferation, and mitosis are more prognostically relevant if we compare it to the necrosis. So necrosis may be seen as an irrelevant finding, and the more important ones are the microvascular proliferation and mitosis if we are grading it systematically. But currently, we should avoid it grading histologically, and one must try to do the molecular with the help of ISC. So, location-wise, they are divided into supratentorial, posterior fossa, and spinal canal. The supratentorial ependymomas may show RELA fusion positive, or now it is called as ZFTA fusion. So, the partner of ZFTA is more commonly RELA, and the other type is GAP1 mammal D1 fusion positive. So these are the two groups in supratentorial ependymoma. This ZFTA mutant ependymomas have poorer prognosis, and as I discussed before, that the rosettes are less commonly seen in this ZFTA fusion positive. We will come across one case of this entity. Then posterior fossa ependymomas are of two types: posterior fossa group A, which are more commonly seen in pediatric type. This also shows K27M3 loss. Then adult type, which shows K27 wild type expression. Then spinal canal, they are cervical or thoracic, which show MIC and amplification. They are associated with poorer prognosis. Then in the spinal canal, they are classical myxopapillary ependymoma. But now the myxopapillary ependymoma is now classified into grade 2. Earlier it was classified as grade 1 because it, it's difficult to resect the entire tumor in myxopapillary ependymoma because it is quite fibrotic and it invades the surrounding tissue. So it's very commonly it is associated with recurrence. So giving it grade 2 allows the radiation therapist to give it radiation and preventing its recurrence. So they have upstaged it to grade 2. This is not of much use. We have already discussed. Now coming to case, this is 35-year male presented with left frontal lesion, complaining of headache, nausea, and vomiting. So this is the picture. You can see that the cells are quite uniform, euchromatic, and dispersed in fibrillary matrix. Here we can see this area of necrosis, although not very useful to indicate the grade or molecular or grade or prognostic implication. But yes, the cellularity is quite high. Here we can see some vague rosette formation present around the blood vessels, but here the cells are arranged in sheets. But yes, we can see that the cells are not looking like any other glial tumor. They are quite uniform. They are looking the ependymal cells on. GFAP is positive, highlighting the vague rosette formation. EMA is focally dot positive. If you can see the dot positive expression in perinucleus. L1 cam is positive. So this is very important. L1 cam is a cytoplasmic expression which comes as a result of RELA fusion. ZFTA and due to its mutation. And KH67 is high, so the diagnosis is supratentorial ependymoma, ZFTA fusion positive. In this picture, I have included because one case came to us, whether it's an ependymoma or some other entity. So while turning the pages, I could see that there is one entity, astroblastoma MN1 altered. So this is very typical of that morphology, and that is again supratentorial. This entity also shows EMA positivity. This is also negative for olig-2, and but the morphology is very different. Again, there is one morphological variation which is papillary ependymoma, which looks like this entity. But the reverse polarity, we can see the reverse polarity around these vessels. The tumor cells, the nuclei are present away from the basement membrane. So this reverse kind of polarity arrangement, abundant cuboidal or columnar kind of appearance, and present around the vessels, giving rise to the papillary kind of arrangement. They show typical EMA positivity, all is negative, and they also show D240 positive. That is, podoplanine is also positive.
We started doing histone G34 after in last few months only, and we have come across only one case. Even those cases which appear to be not midline, and even in adults we get to we see H3K M more 27M more often, even in adults. So it is a good practice if we add H3K27M in all IDH wild type gliomas, irrespective of age. Recently, I saw a case of 59-year or 54-year-old man with H3K 27M mutant glioma. So IDH wild type, I think it is advisable that we should add the at least H3K27M in our routine. You have any questions? Kanchan, you are asking how to differentiate between diffuse astrocytoma grade 2 and low grade glioma on morphology and IHC. Grade 2 is also thought to be gliomas, thought to be low grade only, but in pediatric age group, we need to add a few more markers. Especially a minimum which should be added is BRAF V600E. When we say pediatric, we don't mean 12 years and below. Anybody below 30 years, we should add BRAF V600E as a routine marker in investigating diffuse astrocytoma. Morphologically, as was told that that you should do olig-2 routinely. Some will be olig-2 positive and some will be olig-2 negative. And add BRAF in your routine practice, that will help you a lot. Otherwise, as per our latest WHO molecular, I think in more than sequencing NGS is what is required. Different type of sequencing, pyro sequencing or Sanger sequencing. Other than more than that, what we require to now, maybe in another 5 years, need to put everything to NGS. There are now panels people are developing for adolescent, pediatric and adolescent glioma panel for NGS, adult glioma panel for NGS. So maybe they will be available soon. Okay, so Saturday next is going to be our last class. Thank you. Thank you very much. Good night.